thank you very much. We're going to spend, I'm going to try to get this done in about 50 minutes so that we have a little bit of time to answer some questions. And I'm going to just advance my slides here. 1 second. I wanted to begin with this quote from Steve Jobs because I think it really captures the importance of data collection. If you define the problem correctly, you almost have the solution. And I think that is a very eloquent way to begin the talk. Well, I'm biased, of course, I chose the quote, but really what that's encouraging you to do is when we have a problem and the problem is morbidity and we want to reduce morbidity, first thing you need to do is accurately define the problem. And as we walk through this talk, I'm going to hopefully convey to you that even in Canada, where we have a very robust system for tracking morbidity and mortality across units, there are lots of questions that are coming up about how one even defines the problem correctly. And so there'll be a little more on that as we go through. The objectives are relatively simple. I'm going to introduce you to the Canadian landscape of neonatology and let you know how things operate here and how we collect our data here. We're going to look at center differences in outcomes and show you that probably, well, not probably, we would be no different than I'm sure the units in this network, where some units have better outcomes, some units have worse outcomes. But the question is, what can you do with that information? And then we're going to look at what are the best practices towards reducing three things: BPD, IVH, and NEC. Why those three? Well, we have to fit everything into a 50-minute talk. There are other things such as ROP that I could have talked about, late onset sepsis, but in the interest of time, I've picked three that we can explore together. So for those of you who, some of you may be aware, some of you may not be aware, back in 1995, so it's 25 years ago or 26 years ago, Shu Lee, who was a neonatologist in Toronto, I worked with him also in Edmonton. Shu Lee started the Canadian Neonatal Network. And the concept of the Canadian Neonatal Network, which something you might be able to relate to you, is when you have a country with only 36 or 30 or 35 million people like Canada, probably closer to 30 million back in 1995. One of the challenges is that when you're looking at single center outcomes, there's lots of bias in there. There's lots of problems with extrapolating to the rest of Canada, different geography, environment, transport times, all of these things, genetics even, as you go across a country as big as Canada, that may play a role in determining outcome. So the vision of Shu Lee was to say, let's take all the units, that's 32 units in Canada, and let's band them all together and submit data annually so that we can come out with an annual report about sort of the state of the union, if you will. So as I mentioned, we're a relatively small country. Currently, as of now, it's 37.6 million people. And when you look at the data from the Canadian Neonatal Network, and this is from the 2019 report, you can see that out of 32 sites, we had 14,868 infants. When you look at breaking these down into smaller cohorts, as you see in the 4 boxes below, when you can start to examine babies under 1,500 grams or babies over 33 weeks, you start to be able to get some reasonable numbers. 2,956 infants under 1,500 grams gives you some degree of ability to examine outcome. So that's exactly what the CNN is about. Now, for those of you who are familiar with the concept of positive deviance, I will keep this brief, but I will let people who aren't familiar with it sort of come to understand it. I read this book probably about 10 years ago by Richard Pascali, and the concept of positive deviance has been embraced in something called EPIQ, which we'll go into in a couple minutes. The concept of positive deviance is when you have a problem, and I'm not talking about a small problem, but I mean, a significant problem that you as an organization or as a country need to deal with. What you want to do is you want to go and you want to find those areas of the country or those areas of your population that have the best outcomes with respect to that condition. And then you want to examine very critically by observing them, by documenting them, what exactly they are doing that is different from other units that have worse, or other places that have worse outcome. So that's the concept of positive deviance. And that concept was applied back in the early 2000s to the creation of EPIQ. Now, for those of you who are not familiar with EPIQ, it's evidence-based practice for improvement in quality. The concept of EPIQ was to look at the 32 sites, to take the data that we're getting from the Canadian Neonatal Network and ask ourselves, what is it about the sites that are performing the best that is making the difference? And so to that end, in EPIQ 1, which was in the early 2000s, there were 12 sites out of the 32 that participated. And the concept that the things that they looked at were nosocomial infection and BPD. And so what happened was teams of neonatologists, nurses, RTs went to these centers that on the Canadian Neonatal Network had the best outcome, and they critically examined, how do they ventilate? What is their antenatal steroid rates of use? How do they use antibiotics? Do they use macrolides, for example? What do they use to disinfect their isolates? How often do they disinfect their isolates? They looked at all of these things with a critical lens and said, what do the best places in the country do in order to achieve those results? And then the concept was, can we then apply that information back to the other units and see a sustained improvement? And so that formed the basis very much so for EPIQ 2, which tackled 5 main problems that you can see over a 4-year period. And so it was very much like a PDSA cycle of planning the observation, doing the observation, studying, finding out what the differences were, and then applying them with 3 years of intervention. And we'll go through what happened with that in a moment. EPIQ 3 has involved basically continuous quality improvement, constantly updating the literature, looking at best practice, applying those best practices, and seeing what your outcomes are. One of the challenges with EPIQ, though, and this is a philosophical question that comes up, is if you're going to look at outcome, one of the questions that needs to be asked is, if you're improving over the years, nobody will question what you're doing. But if you're not seeing an improvement, are you actually applying everything in the bundle? And we're going to go through these bundles, but are you applying everything in the bundle? And if not, why not? And if you're not seeing improvements, maybe you should apply things in the bundle. And so that's one of the challenges with EPIQ is we don't have measurements of acceptance of all recommendations, but it's never been a requirement that you accept all the recommendations. So what did EPIQ show? So when we look at this 2019 paper by INEO, and you may even be part of INEO. I'm sorry, I'm not aware if anyone here who's listening was part of INEO, but the gist of INEO was, let's look from 2007 to 2015, and let's look and see what has happened to 2 things. What has happened to chronic lung disease, and what has happened to a basic, the light gray line is a composite outcome. The composite outcome with BPD is the top line. The composite outcome of these 4 or 5 outcomes like ROP, late onset sepsis, that's in the light gray line without BPD. And what they found was that only 2 countries, that was Israel and that was the Canadian Neonatal Network on the top right, demonstrated a sustained improvement in their outcomes over time. You can see from the top right graph, though, the bulk of the improvement was in reduction of BPD. Now, what's the difference between all of these places? One of the differences, and you can see that the UK is on the bottom right, one of the differences is we implemented EPIQ in Canada, and it's speculated that the reductions in BPD over time may be in part related to the great work that is done through the Canadian Neonatal Network and EPIQ to interpret what best practice is and then apply that for sustained change. So that's some evidence that suggesting that the great work that's being done with EPIQ might be making a difference. Not so much to some of the other outcomes, but at least to the realm of BPD. One of the things that was, Alec, that you spoke about at the beginning was 22 weeks. And you talked about the lack of experience due to very small numbers. And here what I'm showing you is one of the benefits of having the Canadian Neonatal Network, which is all of our babies under 1,000 grams. I'm sorry, I don't have the total number here, but you saw under 1,500, there were about 2,500 babies. And what you can see in the green line, these are all neonates, including admissions and delivery room deaths. Red is all neonates who received active care. And blue, the blue line, is CNN admissions, excluding deaths in the delivery room. And so what you can see is, you asked about 22 weeks. If you look at 22 weeks, we're seeing about a 40% chance of survival if you make it to the NICU. The survival is about 30% for all infants who receive active care. And you can see that, you know, when we're talking about outcomes with families, by the time we reach in Canada 26 weeks of gestation or 800 grams, our outcomes in terms of survival are in excess of 90%. And so this is useful information. Having said that, we know that there is site variability, so it's important to know your own outcomes. As a plug, not for my work, but for the work being done in Sweden, there is some great research out of Uppsala that's come out in the last year looking at the difference in outcomes with active care, in which you believe that you can resuscitate all 22 weekers, and those in which you're more selective. And what that's demonstrated is, if you have a universal approach to resuscitating 22 weeks and your team believes that you can resuscitate and be successful, your outcomes are better. So this is not the case in Canada, that we have universal acceptance of resuscitation at 22 weeks, but certainly the guidance from the Canadian Pediatric Society suggests that this is a decision that is worked out as a shared decision model with the family, and that's something I endorse as well. So let's move on to chronic lung disease. So from the Canadian Neonatal Network, which I will now call CNN, because I'm going to find it that I'll trip over my tongue too many times with that long 3 words. So with the CNN data, and I'd be curious, and we could certainly talk about this in discussion period, how your results might compare. But when you look at chronic lung disease overall, under 25 weeks, it's really almost universal in Canada. There's roughly 85% of babies under 25 weeks will be diagnosed with chronic lung disease. The difference between them, the mild chronic lung disease would be those kids that are on nasal prongs and oxygen. Moderate CLD would be those kids that are dependent on CPAP, under 30% oxygen. And severe chronic lung disease would be those kids that are on CPAP with greater than 30% oxygen or are ventilated. And so you can see that thankfully, less than 30% fall into that category under 25 weeks, and it drops off steadily as you go up in gestation. So we certainly in Canada have a problem because one can always do better. And the question is, how do you do better? And we're going to get into that. I talked at the beginning about the concept of positive deviance. And so this graph plots expected chronic lung disease at 36 weeks by type of unit, size of unit, excuse me. And on the y-axis, the actual chronic lung disease for the unit. So with the way this, the way to look at this graph, you can see the number 1 with the grayed out line horizontally. Any one that falls under the line of 1 is a unit that is doing very well. Any line that follows above any dot that falls above is a unit that is not doing as well with respect to chronic lung disease. So when EPIQ was done, what happened was the units that were And I should have mentioned the pink lines are the upper and lower 95th percentiles. When you look at the lines, for example, Unit 19, Unit 23, Unit 22, Unit 8, all that are very, very low in terms of their chronic lung disease versus expected. These are the units that you would target when you're wanting to go for a visit and see what are they doing that other units are not. So coming out of EPIC, and we're going to go through it, and I've highlighted the parts or the points that I think are really important to see. But although I believe this is being recorded, so you can look at this in detail afterwards. We don't have time to go through every point. But coming out of EPIC, we get bundles, which are deemed to be based on EPIC, based on evidence, based on site visits, looking at, again, at the best outcomes and what they do. These are the practices that we believe in Canada lead to the best outcome. And so beginning in the delivery room, we will use, the recommendation is to use CPAP as high as 5 to 8. We don't recommend the use of high flow nasal cannula, which I know is controversial. I'll get into that in a minute as to why I believe CPAP would be superior. The other thing, excuse me, that we do, and it's a bit variable here in our center in Winnipeg. Our approach is any baby who's on a CPAP of 7 or more in the case room and needing an FiO2 over 30%, we give surfactant to. However, the recommendations from EPIC would be up to 0.5. Excuse me. Something that's come right, this is new as of 2020. Weighing all the evidence, and there's been several systematic reviews looking at this, outcomes are deemed to be better with the LISA or MIST technique. And so the recommendation is to give MIST, minimally invasive surfactant treatment or therapy, to infants who are greater than or equal to 26 weeks. The reason for not giving it before 26 weeks is the high likelihood that these kids will need to be intubated regardless. Having said that, I'm sure I could get people who would quote me babies at 24 weeks or 25 weeks who were never intubated. So that is somewhat controversial. With respect to MIST, I think there's still many questions that we need to answer. One of the things that I think is still not clear is which babies are actually the ones that will benefit. I was part of a national discussion on this, which was wonderful to have. And, one of the questions that comes up is, what is the ultimate point? Do we believe that MIST is the best way to give surfactant, or do we believe it is the best way to give surfactant to avoid chronic lung disease in those that are at risk? So for that reason, if you have a 36-weeker with TTN or let's say RDS, and they need surfactant, if you choose to give it via the MIST technique versus the Ensure technique, what in the end are you really doing in terms of difference? Is it less painful? We don't know that. At least I don't believe we know that through comparisons looking at pain infant profile scores, looking at physiologic data in terms of heart rate, blood pressure, intracranial pressure, NIRS. We don't have that information yet. And then which surfactant? One might think that you should use, in all cases, Curasurf as a low volume surfactant or another low volume surfactant. However, there has been research done, good research done out of London, Ontario, looking at the use of Bless, which is what we use here in Winnipeg, and that's at 5 milliliters per kilogram. And that was shown using the MIST technique to also be successful. And then the final question, which needs to be resolved, is pre-medication or not. This is something that's a bit of a hot topic. Do you believe this is a painful procedure that needs pre-medication? But you have to weigh that against if you give fentanyl or morphine or whatever medication you wish to give, if that suppresses respiration, will you wind up having to intubate the baby? Here in Winnipeg, what we are doing is we are using MIST, and we give 0.5 micrograms per kilogram of fentanyl as a single dose, and have a second dose on standby in case that's not sufficient to sedate the infant. and then give the surfactant. I won't be able to tell you, as I imagine questions might come up about how successful this has been in terms of avoiding intubation. We've just started giving MIST in the last 4 months, so we don't have that data yet, but that's something that we certainly are auditing. We have an audit sheet that we used for every use of MIST, and so perhaps if I come back next year to talk about our experience with MIST, I can share that with you. Continuing on with CLD, this is a bit of a hot topic, is the use of prophylactic hydrocortisone. I don't know if any of your units are using that, but after a great amount of deliberation, the EPIQ group came down on the side of suggesting that it was reasonable to consider, didn't say you should use it, but to consider the use of prophylactic hydrocortisone to reduce BPD. And so we'll talk a little bit about that as well. The other thing that's, I think, a bit of a hot topic, and I certainly share on social media whenever I see this come along, is the use of macrolides to reduce the risk of BPD, presumably by treating or eradicating ureaplasma or ureolyticum in those patients who have it. The evidence goes back and forth on this, but at the moment, the EPIQ group was not recommending the routine use, and the typical drug that would be chosen in that case is azithromycin. Looking at, as I mentioned, I said we would look at prophylactic hydrocortisone. Whoops. This, and you probably are aware of this, many of you are probably aware of this, was that the individual patient meta-analysis that was anchored by Christy Waterberg, who had done much of the research in this over the years. She was behind the PROPHET study, as you likely know, back in 2004. What was interesting about this paper was that in an individual patient meta-analysis, what they did was they only included studies in which they could get the original data from the patients. And so by having access to the original data, they could look at things that might not have been looked at in the first study, or sorry, in the individual studies. So they grouped all these together, and generally speaking, as you can see on the bottom, the duration of exposure was anywhere from about 9 to 12 days, and it had to be prophylactic. And what they found was that the use of prophylactic hydrocortisone did in fact reduce the risk of BPD or death from BPD. So survival without BPD at 36 weeks was 53% in the hydrocortisone group versus 45% in the placebo group. So on the surface, when you see this, you would say, well, that is pretty clear and gives us a pretty clear direction as to what to do. Things get a little muddied though when you look at the subgroup analyses, and what you discover is that the benefits were really only seen in females. And so it may well be that the male disadvantage that we all know about from neonatology overcomes any potential benefit of hydrocortisone. Also, the reduction in BPD was only seen in the group greater than 26 weeks, greater than or equal to 26 weeks. So again, the question becomes, much like MIST, is there really going to be a benefit under the 26-week group? Is the premature nature of the lung too big a barrier for hydrocortisone to overcome? And that might be the case. Another thing that's been shown consistently through all of these research trials is that the presence of chorioamnionitis is a risk factor for adverse outcome unless you give hydrocortisone. So another approach might be, and this is in the CLD bundle, does it make sense to restrict the use of hydrocortisone to infants whose mothers have chorioamnionitis? The problem there, of course, is how does one differentiate histologic chorioamnionitis from that seen clinically? Because you'll certainly miss some. When you look at influence on death before discharge, again, the hydrocortisone had more impact in the greater than or equal to 26 weeks group. And one of the downsides was in the under 26-week group, there was an increased risk of sepsis. And lastly, use of indomethacin in combination with hydrocortisone put babies at risk of spontaneous intestinal perforation. So on the surface, you would look at this and you would say, well, under 26 weeks, babies who are exposed to hydrocortisone suffer an increased risk of sepsis and have no impact on death and have no survival at 36 weeks without BPD. The fly in the ointment, though, is in a follow-up analysis of the outcome, neurodevelopmental outcome of these children. The kids, believe it or not, under 26 weeks who were exposed to hydrocortisone had better neurodevelopmental outcome than the kids who were greater than or equal to 26 weeks who had no impact of having hydrocortisone. So this is a hot topic. I think there's much more to be written, and I look forward to seeing how this all plays out. As we continue on with chronic lung disease, the recommendation is for volume targeted ventilation. Interestingly, there was, for those of you that are on Twitter, there was a post that I put out just yesterday actually on this very topic as a paper came out looking at outcomes retrospectively from a unit that used either pressure limited, time cycled ventilation, or volume targeted, and found reductions in oxygen requirements and reductions in length of ventilation with volume. So I think that's just an example of the literature that's out there. Something that I think is controversial will be those with evolving BPD who are over 2 weeks to use volumes of 5.5 to 6 per kilo. I can tell you in our own unit, we do not agree with this. We don't use volumes that high, although this may in fact have more to do with avoiding high frequency ventilation once they have established chronic lung disease. One should try to extubate as clinically appropriate to minimize invasive ventilation. The argument for that, it really comes down to something that I've said many times before, which is no one should have 100% success rate at extubation. If you do, you're extubating way too late. And the last point here is do not use high flow nasal cannula in the immediate post-extubation period. In particular, under 28 weeks, there's insufficient evidence. This goes back and forth. I've seen papers, and I'm sure many people in the discussion period could quote me papers that suggest high flow nasal cannula is just as effective, less invasive, easier to apply. One reason it may be inferior, though, in the smaller babies is that here's a study from 2018 in archives, 2020 in archives, that looked at the effect of an open mouth. And so the control, if you will, was CPAP of 6, and the measured PEEP was in fact 6. When so they compared that with different flows, 2 liters a minute, all the way up to 8 liters a minute. And what you can see is with the mouth closed, you can get that 6 centimeters of water pressure with 8 liters of flow. You can even get 5 with 7. You can get close to 5 with 6. But when you open, that's what when you look at the difference between mouth closed and mouth open, you can get wonderful pressures with the mouth closed. You can range, even with 5 liters a minute or 4 liters a minute, you can get up to close to 5 centimeters of water pressure. But as soon as that mouth opens, with high flow, the pressure drops down to 2.9, 3.3, 3.5. Even with 8 liters, you only get to 5. So I've shown a chin strap there as a way to get the mouth closed. So I'm not saying one can never use high flow nasal cannula, but what we did find in the EPIQ program was that one thing that was in common with all of the units that had higher rates of chronic lung disease was that they transitioned early to high flow nasal cannula. So I think high flow nasal cannula has a role. I think certainly for those infants who are suffering from some nasal breakdown from CPAP, after a while, it's okay to transition them over. But as an initial step, it's certainly not recommended. Oh, and finally, we use this in our units, daily histograms. So a histogram is available on most monitors. So you can pull off a 24-hour oxygen saturation histogram. And we use these histograms in order to better guess when it's a good time to try to reduce CPAP or even take it off. I typically look at the less than 80% and 81 to 85% bars. And if I see that there's a significant portion of the day spent in that area, it tells me the lungs have not yet healed enough to take off the CPAP. What significant means is a matter of debate. In a fresh newborn, I like to see those numbers be 0 before I stop CPAP, like in a baby with TTN. In a baby who, let's say, was ventilated for a month and has chronic lung disease and is on oxygen, I accept that they're going to be on some amount of oxygen. So typically I look for under 10% in those bottom 2 bars combined. So has EPIQ made a difference? So this is one of our centers showing that over time from 2013 to 2019, if you look at the St. Boniface Hospital trend line, it's rather flat. We haven't seen a huge difference in the rate of BPD. Having said that, in that time, we started to resuscitate more and more 23 weekers and some 22 weekers who almost have universal BPD. And therefore, that may be the reason why the trend line has tipped up a little bit. But look what's happened to the national average, much higher. So Winnipeg, who has adopted virtually all of these steps in the bundle, has seen a difference. When you look, interestingly, at these are survivors, when you look at them, what you can see is a marked improvement in BPD under 29 weeks, whereas the national average has gone up. So I'm very proud to say that Winnipeg has great rates with respect to their BPD rates. This, I think, is some degree of evidence, not that BPD, because you could say, well, what about the rest of the country? What has happened there? Again, the question becomes, has everyone actually adopted the bundles? But certainly where we have adopted much of what's in the bundle, we are seeing much better outcomes. So moving on to necrotizing enterocolitis. This is one of what I would consider a neonatologist's worst nightmares. So what does NEC look like across the Canadian landscape? Not surprisingly, when you look at the rate of NEC under 25 weeks, it's about 15%. It drops to 8% at 25 to 26 weeks, and so forth and so forth. Death is not rare. If you have NEC, about almost 1 in 2 babies under 25 weeks in Canada that have NEC will die, so about 40%, and that drops to 1 in 5 at 25 weeks. This slide I thought was important to show you because what it demonstrates is we are not consistent across the country, and this is the whole principle of EPIQ, is these are all the 32 sites, and when you look at the different sites, and I don't know which site is which, and the red bar is medical treatment only, the blue is medical and peritoneal drainage, the hashed is surgical treatment only, and the orange is surgical and peritoneal drainage. So you might look at a place like AC and say, well, there's a real problem. Whereas S, U, and V and ABC, who have almost no NEC or no NEC, the question is, what is different about those sites? So when we look at strategies to reduce NEC, the first one is promoting of human milk. And one of the ideas here is it's never too early to start that discussion. Start it in the antenatal consult. Ideally, the obstetrician should be talking about the benefits of human milk at the visits so that we optimize the amount of mother's own milk received. Another thing that's a hot topic would be the use of products that are human-derived, human milk fortifier as a part of an exclusive human milk diet. I don't believe that the EPIQ group has weighed in on that, but that's something that people certainly are considering, as well as the use of probiotics. Something that's critical is getting minimal enteral nutrition in within the first 24 hours, with rare exceptions. I've put on the left what our own units do. We have a policy of starting minimal enteral nutrition, or MEF, within 6 hours of age. And the only exclusions we have for that is if you are on greater than or equal to 2 vasopressors or inotropes for blood pressure, or you have obvious signs of bowel obstruction. Otherwise, all babies who are very low birth weight, under 1,250 grams, get minimal enteral nutrition in this way. Something that I think is a bit controversial, or very controversial, is when blood transfusions are indicated. They have suggested considering discontinuing feeds for a period of time, pre and post transfusion. I can say that's not something we've adopted. But one thing we have adopted is the use of ibuprofen instead of indomethacin for PDAs. One of the things that I talked about at the beginning was and it goes back to the quote from Steve Jobs about if you want to solve a problem, first you need to define it. One of the problems that we have is that the diagnosis of NEC is in evolution. I can't speak to what happens in your units, but here in our units, we rely a lot on POCUS, so point of care ultrasound, for diagnosis of all sorts of things, RDS, TTN, pneumothorax, and more necrotizing enterocolitis. And I'm going to show you our own data that has been submitted for publication, but not yet accepted in a slide. But the diagnosis in the Canadian Neonatal Network is a radiograph, so an X-ray demonstrating stage 2 or 3 NEC according to Bell's classification. But what do you see if you use ultrasound? And so when you look at
Are you okay, Mike?
yeah, no, I'm
Sorry.
I'm fine. Is Yasser online, or was that an automated screen? Okay, that must be an automated screen. Can you hear me?
Yes, we can hear you. Yeah.
Okay, so I was just going to say this slide is from my colleague, Dr. Yasser El-Sayed, and I hadn't actually realized that it has audio recorded on it. So as he was saying, this is the unpublished work that I was referring to. We looked at our own center at 144 patients who had evidence or suspected intestinal injury. When you broke them down into those that ultimately were concluded to be normal, versus those that had food protein induced enterocolitis versus true NEC. The difference between radiography, traditional radiography, and ultrasound was astounding. So those kids who ultimately were found to be normal, and by normal their bleeding stopped, they were concluded they actually never had any problem, it was just one bloody stool. 55% of radiologists had called NEC on an X-ray. 0% of those babies on intestinal ultrasound were found to have abnormalities. Similarly, for the enterocolitis, or cow's milk protein, 57% of X-rays were called NEC, 36% with ultrasound were suggestive of an abnormality. When you looked at NEC, though, the sensitivity was astounding. 100% in each case of mild, moderate, and severe NEC were identifiable with ultrasound. Radiologists reading X-rays were only accurate about 4 to 5 times. And how do I? So one of the questions that may come up here is, well, how do you know the ultrasound's right and the X-ray's wrong? This is based on the clinical symptomatology. So this would have been babies who either went on to have surgery for NEC, so that was proven. Babies who continued to pass bloody stools, had strictures, or had abdominal distension with ongoing bloody stools after the initial X-ray, demonstrating evidence of NEC. So the use of ultrasound is quickly, I think, replacing, at least in our institution, the use of X-ray for making this diagnosis. So this becomes a major issue when you're looking at best practice, because if we know that radiologists are not entirely accurate when they make this diagnosis of stage 2 and stage 3 NEC, what is the difference from one center to another? And what if some centers are using ultrasound? So comparing apples to apples becomes a bit of an issue. Oh, sorry, I'm going to move on here. So how do we compare to the national average? Well, our trend line, you can see, has dropped. We started off quite a bit higher than the national average. I'm happy to say, as of 2019, these are babies under 26 weeks, our rate of NEC of 1.96% under 26 weeks is the best in Canada. So we've come a long way. And lastly, we're going to tackle intraventricular hemorrhage. This graph is from the CNN and looks at IVH under 33 weeks. And what you can see, not surprisingly, is under 25 weeks, about 50% of babies will have a germinal matrix hemorrhage. If you look at blood within the ventricle, that's also close to 50% under 25 weeks. Intraparenchymal lesions, grade 4 IVHs, they certainly drop down to 20% under 25 weeks. And they drop off precipitously after that. And PVL happens, and at about 5% in the under 25 and the 25 and 6, but then drops off considerably after that. Not surprisingly, after you've seen the evidence with NEC, there is great variation across the country in terms of rates of cranial ultrasound abnormalities and severity of cranial ultrasound abnormalities. So one would question, for example, what is going on with center eye, where all of the abnormalities reported are severe. It does raise into question some of the data that's being sent, and that's always one of the issues, is how reliable is the data. We have in the last couple of years standardized in the CNN how ultrasound is read using more reliable and standardized measurements of ventricular index in the reporting, so you can compare apples to apples. So what are the things that we can do to reduce IVH? Well, one of the things, is something that I think most of us already do, which is trying to avoid both hypocarbia and hypercarbia, as this can have effects on the perfusion, arterial perfusion of the brain, either vasoconstriction or vasodilation. Tolerating pHs down to 7.20 and avoiding the use of bicarb. This is something that I think has been an evolution. When I was training 20-something years ago, we were using a pH of 7.25. This has gradually moved down to 7.2. And what that does is allows you to use less aggressive ventilation. Minimal handling has been a hot topic. I don't know if your units are using this, but there's been a strong move to, in the first 72 hours, trying to avoid handling of these infants and considering raising the bed by the head of the bed by 30 degrees for the first 72 hours. The evidence for this, surprisingly or not surprisingly, is very, very sparse. This is a study from, 2018, looking at midline head positioning with elevation of the bed, which in short, I'll draw your attention to the far right, showed that when they looked at grade 4 degrees of IVH, keeping the bed flat and having the head down versus having the head up showed a statistical significantly increased risk of severe IVH. And so some units have made the argument that they should follow this path. To be honest, I tend to fall on the side of saying, I don't know, but probably can't hurt to have the head of the bed elevated. And, as I posted just the other day on social media, is it really, that shocking that perhaps it might be beneficial after babies have been floating in an amniotic fluid and isolated in the dark for so long to maybe just leave them alone for a few days after birth? I'm not suggesting abdicating our responsibility to test these infants and make sure they're ventilating properly. But I am suggesting that going in and weighing them every day, doing multiple ultrasounds might not be in their best interests. Delayed cord clamping is something that is recommended under 32 weeks. The Canadian Pediatric Society is coming out with a new statement soon, and will be likely advocating for considering even going up to 2 minutes of delayed cord clamping, as there are some benefits there. Another hot topic is prophylactic indomethacin. That's a story unto itself, but some units, ours is one of them in Canada, are not allowed to use prophylactic indomethacin. As Health Canada has said, it's not indicated for babies in the first 72 hours of life to reduce IVH. Other units in Canada are using it, so it did make its way into the IVH bundle. When you look at how we're doing, this, I think keeps us humble. Our national average was lower, but in the last year or so, we've seen a rise. So I wanted to be honest and include this slide. I could have picked a different thing to show you, such as our late onset sepsis, which has actually done quite well using the EPIQ bundles. But something's happened in the last 2 years. I don't have the 2020 data to show you, but the data are very similar to 2019. So it just goes to show you we do have some work to do. And one of the things that we do need to look at is, are we actually following all the things in EPIQ that we could be? So in conclusion, I hope one of the things that I've demonstrated today is that if you don't know where you stand, you don't know where to go. The importance of collecting accurate data is critical to figuring out how to solve a problem. If you weren't aware of what positive deviance is, I hope you now understand that the concept of positive deviance actually is what forms the basis of quality improvement, looking for the best outcomes and then adopting those strategies and seeing if you can achieve similar outcomes. In some cases, such as chronic lung disease, I hope, and NEC, I've shown you that QI principles can make a big difference. They can actually make a difference and have impact. One of the unresolved questions, though, is because there is no authority of the EPIC program to enforce practice change at a local site, it's imperative that each center look at their outcomes, and if they're not improving, re-examine why they may have chosen not to adopt something in the EPIC bundles. And you can imagine, you've got, I think you said 14 sites. There are brilliant people at every site who are well read in the literature. How one interprets that literature, though, is often shockingly different. And so I would encourage people not to stick to their guns, and not expect different results if you do the same thing over and over again. And then finally, and this is, I think, something that will need to be explored, not just on the Canadian landscape, but I think globally, is in order for us to compare, because I haven't shown you slides comparing, for example, the UK experience or North American or American versus Canadian, but if we're going to look globally at who has the best outcomes and try to mimic those outcomes, we also need to look at how one defines the diagnosis. And in the example of necrotizing enterocolitis, I hope I've conveyed to you that if you are a center using ultrasound to diagnose, it is going to be very different potentially than centers which use X-ray to diagnose. And so with that, I thank you, and I'll stop sharing my screen and open this up to questions.
Thank you, Mike. That was an absolutely excellent overview of how you would approach morbidity and quality improvement in the context of benchmarking practice. And I think,
thank you.
To an extent, from our perspective, we're probably a little bit behind in that we have a similar network approach to it, where we submit data on, I would say, 10 variables, which include, I would say, IVH, chronic lung disease. NEC has started approximately 2 years back, and ROP. And we have a few other parameters, which are quality indicators, hypothermia on admission to the neonatal unit, where we're compared with all the neonatal units in the country. But I think what is really helpful is that we also submit data to the one network, and that allows us to actually compare ourselves globally. And I'm going to be perfectly honest to give you a little bit of a feel of us, in that on average, we manage about between 45 and 60 babies under 30 weeks of gestation, which might not be a very large number compared to Manitoba. But if we look at our outcomes from that particular perspective, our chronic lung disease rates have traditionally been on the higher side. We've had rates as high as 55% in the last 5 years, only recently starting to come down to about, I would say, 45%. I think strategically, our practice has been very similar to yours, in that most of our babies under 26 weeks will get intubated in delivery suite, receive surfactant, trying to optimize a dose as close to 200 per kilo. We believe in minimal handling, early caffeine, and minimal entry nutrition with breast milk. Having said that, one of the things that has been part of practice is the practice of creep. And we have been using high flow, and I think we have recognized that, we have a lot of babies on it who've kind of crossed the period of their acute lung disease, but have established a more chronic kind of status, who sometimes stay on it for longer than we'd like, with higher oxygen levels. And inevitably, some of those babies then have to go back onto CPAP or even an IV with our respiratory colleagues across the road. So I think gradually, especially for the more preterm babies, we've become more circumspect with how we're approaching that. My question at this particular stage with regards to chronic lung disease, we debated the use of hydrocortisone, and again, our anxieties were against the rise in late onset sepsis that was demonstrated in that study, in the arm that used it, but in the context of our high rates of chronic lung disease, we felt the benefits of actually starting hydrocortisone outweighed those risks, and that actually if we start it as a bundle where we're able to monitor and continuously monitor our late onset sepsis rates, actually it made sense. So we actually implemented this about 8 weeks back
Mm,
for all babies under 28 weeks, and
okay.
we're using it in a twice daily dose. I mean, we've only done a few babies, but I was keen to get your experience on that. How do you feel hydrocortisone has been, and have you used it for a long period, or has it been a recent implementation?
I love this question because it exposes it exposes the problem with working in larger groups. So first off, we have not used it. Sorry, that's not quite true. I did use it. I believe in it. I really do. You know, I think it makes a lot of sense. I think the physiology makes a lot of sense. There's a recent paper that has come out looking at cortisol levels in the first 12 hours. I don't know if you saw that, you know, and trying to determine, you know, might that be a way of using precision medicine to target those that are most likely to benefit. So we're looking at that right now. I can tell you across Canada, I did a survey because I just presented so I presented prophylactic hydrocortisone, the Premalox study, to my group back in 2018. And back then, they just weren't ready to bite. Then in 2020, with the individualized, patient meta-analysis, I presented that and just did a full presentation on that. And again, half the group said, yeah, this makes sense, and half the group said no. So we're still negotiating. I do know across the Canadian landscape, 20% of units are now using it. I see it as physiologically sensible. It's a hot topic because one of the questions that has come up is, should only females get it?
I was going to ask you that question.
And from a health equity standpoint, I just can't get my mind around the idea. Think about twins. What if you had 27-week twins, a boy and a girl? And what if you gave it to the girl and you held it from the boy, and the boy goes on to get horrific lung disease? Now, they probably were going to get horrific lung disease anyway, but the parent will forever look at the girl who did well and wonder if it was the hydrocortisone. And so I'm of the opinion, because also we have to bear in mind, and my background is not in statistics, but I am very much aware the more things you look for, the more subgroup analyses you do, the greater the risk that you're going to stumble upon something which actually has to do more with chance. And so I do wonder if the male versus female is really something that's there, or if we had even more studies, you'd find that disappears. So, but that's the experience, and kudos to you for getting it going. Incidentally, we had 2019, we had 49 babies under 29 weeks, and 2020 we had 50. So our numbers are actually not that dissimilar. Now, having said that, we have 2 level 3 hospitals, and so our numbers are actually closer to 80. So a little bit more than you, but similar.
So there's a question from a colleague of mine.
Yes.
What are your postnatal steroid rate uses, and what do you use the DART protocol, or do you have a modified protocol, or do you not use steroids at all?
That's another great question. I can't give you specifics about our rate of steroid use under 29 weeks. What I can tell you is under 26 weeks, it's almost 100%. The thresh, so I think we've been great. So, and what do we use? That was your other question. The default is the DART protocol. I've been hopeful we could adopt prophylactic hydrocortisone to avoid, giving the DART protocol. However, I will be frank and say we have some kids, and I'm sure you do too, that for one reason or another have horrific lungs. And I know that if I'm going to give them the DART, and this is just from experience, if I give them the DART and they're on 90% oxygen, it's not going to cut it. you know. And so rather than waste it, I have a discussion with the family, and I will start off at 0.3 per kilo as the first as the first round, and do what I call an extended DART. You know, is that scientifically based? Not really, but you know, there are some things that after years of throwing the dart at these kids that have these, you know, on the jet ventilator on a mean airway pressure of 14, you know, 90% oxygen, the dart does nothing. You know, if I shouldn't say it does nothing. You might get them down to 70% or 50% oxygen, but then as soon as you move on to the next step, they start to climb again.
Just another question from the same colleague. So the approach to ducts. So we're a unit which is, I would say, quite heavy on medical management of hemodynamically significant ducts.
Yes.
That sometimes extends to babies who might not be ventilated as well, especially if they're under 26 weeks. So they might have come off, but an echo might show a hemodynamically significant PDA, and the worry then is they might go back on. So it's not unusual for babies to, and we use both proof and paracetamol, you know, for the babies where we
Right.
have a, but he's just curious to kind of get an idea about your approach there.
So the approach, I'll be honest, it's sort of all over. It depends. Like we've got 14 neonatologists. Some strongly believe in early identification of the duct, and so they'll often look. They'll look at 24 to 48 hours with a hemodynamics assessment, and if it looks significant, they'll start ibuprofen. We don't have a lot of people that start acetaminophen, although, or paracetamol. Some do. Some are big advocates for it because they believe if you use it early, it's as effective. And there's literature out on that, looking at early use is as effective as ibuprofen. But your question about level of support, certainly anyone who's ventilated, I think if they're ventilated and there's a hemodynamically significant PDA, we treat it. If they're not ventilated, if they're on CPAP, sometimes we'll sit on them, you know, and we'll just see what happens. I saw somebody asked me about budesonide. What's my take on budesonide? So we do use budesonide administered with surfactant as a vehicle to get it locally into the lung instead of the DART. I'm going to say my experience with it has been less than enthusiastic. I think what I generally see is a transient improvement, which is I think from the surfactant. And then usually within a couple of days, they're right back to where they were. And we've tried giving it over, you know, 2 doses 24 hours apart, you know, and still it doesn't, you know, I know there's evidence out there suggesting that it could make a difference. We just haven't found it, but I think it also probably speaks to the right patient. I think if you give it to somebody with established cystic or fibrotic lung disease, it's too late. Yeah.
Missed the boat.
Mm-hmm.
So just with regards, we've got a question on neck. So traditionally our neck rates have been very low. I think some of the benefits of that being, we have a breast milk bank. We use a lot of donor. We're clearly quite worried about the nutritional aspects of using donor for an extended period of time. But that, as well as I think we have a very high antithetic steroid coverage rate. So well in excess of 90%. It's usually an outborn baby who's delivered suddenly, who doesn't get it. And I think some of that practice comes in. But the one thing that we do, and I'm just asking you because you might argue this is a cheat sheet, and that we do separate our babies who have SIP, spontaneous intestinal perforation, from the babies who have neck.
Yes.
Now, I'm just curious, there's a huge variation across the Canadian neonatal network. And
yes,
are you doing that at the moment in Canada, or is that still, you know, quite variable in terms of how it's interpreted?
No, anyone with SIP is removed. The challenge, of course, is you only really know if it's SIP if you do a laparotomy.
Yep.
You know, but certainly anyone who has an isolated spontaneous intestinal perforation would not meet the criteria. Yeah, so they are excluded. But I do, going back again to my earlier comment, and I don't, you know, I don't mean to speak disparagingly against the CNN or EPIQ, but when I see, you know, bar graphs that look like this, and the Canadian landscape is all over the place, excuse me, and knowing that I'm sure in your group, you know, you get, you know, it's the power of suggestion. You know, if you're on call and you're asked to review an x-ray for a baby who has bloody stool, and you're told the baby doesn't look well, they're mottled, right? And you're told to look at the x-ray. Suddenly, stool in the right lower quadrant suddenly manifests as neck, right? And when the radiologist, because I think about the medical legal aspect of this, when the radiologist is sitting in their room and they get the requisition and it says suspected neck, the bias for them to call it, because they know if they say, no, it looks absolutely fine, well, what they're saying is, it looks fine. You as the neonatologist can now go and feed the baby potentially. And then if the baby perforates and dies, you know, the weight's on them. So I think there's a bias to call it. And so knowing that humans are human, Toronto may be different than Ottawa, may be different than Manitoba. So I actually think I'm not a POCUS person. I can do lung ultrasound, but I haven't done bowel ultrasound. When I see what they show, like when my colleague shows me on ultrasound, the look of neck, the absent peristalsis, the bad perfusion, the, you know, he's even shown me portal venous gas. There's just no arguing, you know, that's what it is, you know. So I think that it'll be very interesting because Canada's really pushing POCUS. So if you, and we have training centers and whatnot. So as the POCUS army, if you will, distributes across Canada, and we start using ultrasound as the modality to make the call, it wouldn't surprise me if we see a smoothing out, you know, of diagnosis across the country.
Just another question. This is from one of our trainees. So the definitions for severe brain injury. So obviously that's data that's submitted through the network.
Yes.
Again, the question that they're asking is, when ultrasounds are reported, are you choosing the worst diagnosis at a particular point of time, or are you choosing ultrasound and an MRI? I mean, how would you make the interpretation of severe brain injury at the point of entry? Because that might also create quite a difference in.
Yeah, I believe it's worst. And like I said, it used to be that the definitions were not as accurate. They were open to subjectivity. And we also knew, for example, that certain units had very high rates. And I guess there was an exercise done where, because there was a suspicion of that, could it be in the interpretation? Some units would call something a grade 3 that others would call a grade 2. And so they sent around some images that had been called grade 3 to different places across the country. And yeah, other radiologists called them grade 2. And so there was an attempt to standardize it. So in the CNN, at the end of the CNN report, and they're available for free. Anyone who wants to take a look, it's CanadianNeonatalNetwork.org. You can go and get the latest report. And at the end, they have their definitions. And you can see that they've now standardized it, you know, with specific ventricular measurements and index in order to really try to, you know, make it more universal. Because you can imagine if you were a unit where year after year you were cited as the worst in Canada, you know, you want to know that, in fact, if you are the worst in Canada, you know, and that it's not just your radiologist reporting it in such a way.
So one of the things that our national audit project and the national data collection unit has stipulated for us is that we have to share our outcomes with the parents in a pictorial format. And usually what happens is, it's tricky because the report comes up in September and there's a kind of a cooling off period by which we have to submit our report, which is usually 30 days, which is January the 30th. So there's a huge push to get the data in. And I mean, you're right, you know, it can be quite embarrassing when you suddenly say that your antenatal steroid or MAC rates are extremely low. So,
right.
One last question. Are you short on time, or?
I can do one more question. I have another
Okay.
meeting I have to go to,
No,
but
that's really kind.
Yeah, that's fine.
So one last question from one of our trainees is with regards to when you counsel parents over there, would you use your denominator as live births versus neonatal admissions? Because obviously survival at admission is much higher, but it's likely to reflect actively resuscitated babies, not the babies who've had comfort care. And we were just curious about your personal approach, because I know this varies between parents.
You know, that's a very good question. I mean, we've actually moved away from giving specific numbers, in part because I actually don't think it matters. You know, like, you know, when a parent hears, you know, I was talking to actually a neonatologist yesterday about this. The psychology is very interesting. If I present to a family, there is a 90% chance of mortality at 22 weeks. What they actually hear is there's a 10% chance of survival, right? And if I present to them that there's an 80% chance if we intervene, they hear there's a 20% chance of survival. So, in fact, this has actually been looked at. There's been research that has been looked at this, and I can't quote you the paper, but what I remember was the two things that actually influence a parent's decision to move forward at the edge of viability, not the data that we give them. The two most important things are, number one, their gut instinct, and number two, their faith, their religion. Those were the two biggest things. And we see that here in our Indigenous population in Canada, or what you would call Indian, perhaps, or North American Indian. In our Indigenous population, almost without exception, it doesn't matter what you tell them. I could say there's a 99% chance of death. They hang on to the 1%. Similarly, in our Muslim population, it almost is to the point where, not to the point, it's not almost to the point, it is at the point where without the imam intervening and saying it's okay not to proceed, and I'm not judging, by the way, I don't mean to sound like I'm judging, it's everyone's right to make these decisions, but I would encourage people to move away from talking about numbers, and I would give more generalities. I would say to a family, so when I speak to a family, I say, most of our babies at 22 weeks that we resuscitate will not survive. Most of our babies, if they do survive, will have these problems. And I go through them in lay terms. But giving them 85%, 75%, 95%, the only time I use numbers, I will be honest, I do use them. When I use them is when I talk about our statistics after 30 weeks. And I'll say to families, we have a 98 to 99% survival without severe disability. And that's important because and I'll end on this, what I tell them is, what you're really losing in the last 10 weeks of the pregnancy is your 24-hour babysitting. The outcome's not going to be any different. But yeah, to give parents numbers and break it down, they won't remember it.
That's really helpful. I can't thank you enough for giving us an absolutely delightful session. Thank you so much for.
You're very welcome.
And a big thank you from Southampton. Thank you.
Okay, thank you. Take care.
Okay,
stay well, everyone. Bye-bye.